Brockton, and it really is my honor and my privilege tonight to host this wonderful, informative event, prostate cancer awareness in the era of COVID-19 pandemic. And there's many different skilled professionals this evening that we'll hear from. I want to thank, of course, the president of the Brockton area chapter of the NAACP, Phyllis Ellis, and I want to thank Dr. Faina Stern, president of AdMeTech Foundation. I believe this is the third prostate cancer awareness that I've participated in as the mayor of the city of Brockton, but we really have some wonderful elected officials, State Rep Claire Cronin, State Senator Michael Brady, and I'll just let you know right now that, of course, Brockton is one of the hot spots and has been one of the hot spots in the Commonwealth of Massachusetts relative to the COVID-19 pandemic. We are thankfully in a yellow classification, down from red, but we have lost 285 residents. 285 residents have perished because of this virus. So I hired in the spring a very skilled MD, medical doctor, Dr. Rick Herman. Rick is my pandemic consultant. He is a former chief of the emergency room at Brockton Hospital, Signature Healthcare, and also at the other Brockton Hospital, Good Samaritan Medical Center, both here in the city of Brockton. And he has been truly a wonderful benefit as we navigate the uncertainty of this deadly virus. And he's going to be able to give some updates tonight. But again, we need to make sure that the city of Brockton and the people, the residents, the constituencies that we serve, that Claire and Mike and I serve, and the other duly elected officials, we need to empower these residents to protect their families and the community as a whole. And we need to truly reduce the spread of the virus. That's it. We need to reduce it. We need to minimize it, mitigate it, and eradicate it. So we also have to be cognizant of the fact that prostate health for us men, and specifically men of color, is extremely, extremely important. And I know that my conversations as the mayor of Brockton, many people, of course, put off going to see their primary care physician and making visits to the hospital because of COVID. But rest assured, please don't do that. Time is of the essence. So I want to, again, thank everybody for their time and dedication to this cause. It's extremely important. We'll have a survivor speak this evening, Darren Duarte, who was a former chief of staff for the late Mayor Bill Carpenter, and now is communications director over at the Brockton Police Department. So wonderful medical people. This is really being taped to educate and inform. So with that being said, I want to thank each and every one of you for taking time out on a Thursday night because of the importance of this topic. And we don't want to shortchange anybody, but I'm going to jump right back into it. Dr. Herman, good evening, and I want to thank you, Rick, for everything you're doing to save lives in the city of Brockton. And if you wouldn't mind, Dr. Herman, if you could please give us an update on COVID-19 and the efforts here in the city of Brockton. Good evening.
Sure, thanks, Mr. Mayor. Let me share my screen and we'll get right into it. So what I'm going to do is give you some background on where we are in the city of Brockton with COVID-19. And so just to put us in perspective, this is, of course, the Commonwealth of Massachusetts, and Brockton is one of the very few cities that overall has more than 350 per 10,000 people. So us, along with Lawrence and some of the towns north of Boston, have seen the highest caseload of COVID within the Commonwealth. And part of the reason for that is that Brockton is faced with a lot of challenges, and this is how we rank in terms of the top 100 cities and towns within Massachusetts in terms of population. And so you can see that some of the socioeconomic factors that are impactful for all kinds of healthcare specifically affect COVID. People of color seem to be more prone to COVID-19, and of course, frontline workers who are interfacing with the general population are at risk of COVID-19, and we rank first in the Commonwealth in terms of our share of frontline workers. What I wanted to do is go over this map of the city of Brockton. This shows where the cases are. And this is actually just a timeline that shows us where the cases have appeared over in the city of Brockton over time from March through present. The blue dot represents a case, a red dot is a death, a gray dot is a recovered case. And you can see that over time, the city has really seen more than its fair share of COVID-19. And we can use this data, this is a heat map, just to kind of show where the cases are, kind of down the central corridor of the city, with some big red splotches that are the nursing homes, because of course the nursing homes were the epicenter of many, many outbreaks, especially early in the pandemic. And just because there are elected officials on the call, this was just a byproduct of the mapping that we've been doing. On the right-hand side shows where the cases are in the city of Brockton. On the left side, the light yellow shows people that are not responding to the census. And I try and use every opportunity I have when I'm speaking public to get people to respond to the census. And we only have a census every 10 years and a pandemic every 100 years. So I don't know if anyone's really looked at the interface between the two, but it seems like the people who are getting COVID may also be the people that are not responding to the census. So here's where we've been. This has been our journey since March of 2020, up to 4,729 cases as of 4 p.m. today. This is the number of deaths. As Mayor said, we are up to 285. That's the big brown line on the top. And the line along the bottom is kind of a rolling average of deaths per day. We've been averaging about 1 death per week now, which has come way down from when we were seeing more than 100 a day. And this is just a curious graph. This, if you look on the left, this is kind of at the beginning of the pandemic, before the 4th of July. This was the breakdown of the different age groups, 0 to 20, 20 to 30, 30 to 40, et cetera. And a lot of people felt like this was just a disease of old people, but of course it's not. It's a disease of everybody. In fact, the average age before the 4th of July was 51 years old. If we look at the last 2 weeks in Massachusetts, you can see the age group is much, much younger. Average age is now 36. In fact, I spoke with Brockton Neighborhood Health Center today. Their last week of testing, their median age was 33. And so this is really becoming a disease of younger people. It's still the older folks that are dying, however. So less of an illness in the young people, less severe illness in young people, but still very severe in older people. This is the testing rate in the city of Brockton over time. Back in the early pandemic, over 50% of the people tested positive. But for the past 3 or 4 months, we've really hovered in the 3 to 4 to 5% range. And that's where we want to be, is under 5%. And if you go to the City of Brockton website today, as every day, we have a dashboard, and the dashboard is chock full of information: how many new cases, total cases, how many active cases there are. That's how many people have yet to be cleared by the Board of Health and are still out there symptomatic or not yet cleared. I didn't get the numbers yet for the day, but I think it's 3 cases in the hospital and none in the intensive care unit. But that's important to us because we want to make sure that we have capacity to care for people in case there are any spikes. And of course, this big yellow box on the right-hand side is the number that everyone is looking at, because this is the average daily case per 100,000 population. And this is what's informing the school departments across the Commonwealth on whether they can open remotely, hybrid, or in person. For the number greater than 8, the recommendation is that go all remote. Between 4 and 8, which is where we are, to consider a hybrid model unless you have extenuating circumstances. And this is kind of what our journey has been through the red, yellow, and green. We did go up into the red area for a while at the beginning of last month, or in the middle of last month. And that was part of the reason why the school system has chosen to go remote for the time being anyway. And we're following that number very, very closely. So with that being said, I will stop sharing my screen and turn it back to Mayor Sullivan.
I want to thank you again, Dr. Herman. Everybody that sees that dashboard, that's a product of Dr. Rick Herman. He spends hours and hours of dedicated time to get the metrics and get the data, working with Dr. Eno Montesor, a newly appointed Executive Director of the Board of Health. So Dr. Herman, thank you. I hope everybody found that information valuable. And if anybody wants these slides after this, we'll be happy, the City of Brockton through Dr. Herman, will be happy to provide those as well. So thank you again, Rick. I appreciate it. I'm going to go on now to Dr. Faina Stern, and Dr. Stern has, of course, given so much time and effort to provide information in previous NAACP Zoom forums that we've been doing. And Dr. Stern, of course, as I said in the beginning, is president of AdMeTech Foundation. So again, I wanted to wish her a good evening. Dr. Stern.
Thank you for the opportunity to participate in this event. My name is Dr. Faina Stern, and I'm a president and founder of nonprofit AdMeTech Foundation. My goal today is to talk about COVID-19 pandemic and prostate cancer, two leading disparities. I will talk about emerging advances in prevention, diagnosis, and treatment of COVID-19, and I will address why prostate cancer cannot wait in the time of this pandemic. The main challenge of this pandemic is asymptomatic infections. It can be anyone, including us. What can we do today to protect ourselves, our families, our communities? It's important to remember 5 steps. Social distancing, avoiding large gatherings. Masks, face coverings. As somebody pointed out, your mask protects me. My mask protects you. Protection of our hands through hygiene or gloves in public places. Protection of our eyes. Choosing outdoor instead of indoor activities. If we follow these simple 5 steps, we can reduce viral spread drastically. The best data indicate that universal masks alone can save over 122,000 American lives and prevent countless infections by early January next year. If you're at higher risk of severe disease, talk to your doctor and learn about resources available in your community. High-risk individuals include senior citizens, young children, aged 12 months and younger, patients with underlying health conditions, socioeconomically disadvantaged communities, African American, Hispanic, indigenous individuals, recent immigrants, struggling with low income, poverty, homelessness, holding high-risk essential jobs, living in multi-generational housing, also pregnant women. If you have flu-like symptoms, if you're exposed to someone who is sick with COVID-19, assume you may have this disease. Isolate yourself to protect people around you. Call your doctor. Utilize state resources. If you have difficulties breathing or chest pain, call emergency services. COVID-19 diagnostics are critical for early detection, controlling pandemic, and safe return to work and schools. Current challenge is to get rapid testing results for prompt diagnosis, treatment, contact tracing, and isolation. There are 2 types of testing widely available today: for live virus active infection and for its antibodies immune protection. Discuss with your doctor what testing is right for you. COVID-19 treatment is likely to succeed in near term. Multiple organizations are working on treatment strategies and their evaluation. Early detection is critical when mild to moderate symptoms reflect initial viral infection and initial inflammation, for example, in the lungs. At this early stage, several treatment strategies have been shown to stop virus replication, improve patient symptoms, and expedite recovery, including antiviral drugs, virus-neutralizing potent antibodies, combination treatment, integrating antiviral and anti-inflammatory agent interferon. Extensive conclusive global trials are currently in progress. About 15 to 20% of patients progress to severe life-threatening disease. On June 16, Oxford University announced the first life-saving drug, anti-inflammatory steroid dexamethasone, which is widely available, inexpensive, and can be readily implemented globally. On August 12, Mayo Clinic-led trial indicated that convalescent plasma obtained from COVID survivors and containing high level of antibodies can reduce risk of death by 35% vis-a-vis low level of plasma antibodies. On April 29, NIH reported that antiviral drug remdesivir expedited recovery in these patients by about 31%. Global clinical trials currently combine antiviral and potent anti-inflammatory agents to maximize patient benefit, and results are expected soon. The most important goal in ending this pandemic is to have publicly available vaccines. The key challenge is our uncertainties if immune protection against the virus is strong enough or if it can last. And yet, growing national and international data show protective immunity for many people after infection, creating hope for effective vaccines. The global goal is to vaccinate billions of people, which will require multiple public and private partnerships. WHO, with multiple partners, established a COVAX facility for equitable vaccine distribution. As of July 15, it was announced that 165 countries with over 60% world population participated in this effort. The goal of US government is to vaccinate 300 million Americans by early to mid next year. To achieve this goal, they support multiple organizations in order to conduct definitive clinical trials and ensure that vaccines are safe and effective, to ensure large-scale production and distribution to the public, and to develop strategies and priority for vaccine administration. Dr. Jerome Adams, US Surgeon General, testified to United States Senate on September 9. I want the American people to hear me say this. There will be no shortcuts. This vaccine will be safe and effective, or it won't get moved along. And when a vaccine is approved by FDA, I and my family will be in line to get it. While we are dealing with COVID-19 pandemic, prostate cancer cannot wait. Unfortunately, men stopped going to clinical facilities out of fear to contract the virus. And yet delays in care can result in reduced quality of life and even loss of life. It is important to highlight that clinical facilities created a safe environment, including telehealth for virtual visits, for ongoing in-person care, for medical procedures, including biopsy and treatment. Delays in prostate cancer care are particularly unacceptable for Black men, who are 2.5 times more likely to die compared to everyone else. And yet prostate cancer is curable when detected early. With early detection, every man survives in 5 years. With late diagnosis, when metastatic spread is present, only 28% of men are alive in the same period of time. The best tool we have today for early detection is blood test PSA, which saves lives. PSA testing, like any other test, is imperfect. In about less than 10% of all men undergoing screening, we see biopsy performed. It is invasive procedure causing pain and infection in some patients. It may be unnecessary. Up to 75% of men do not have cancer. Less than 1% of all men undergoing screening may have unnecessary treatment with associated costs and complications. It is important to know that nothing we can do, including testing, is 100% reliable, and only a small fraction of men have abnormal screening. I would like to address a few things men need to know before and after screening. First and foremost, men need to know if they are at high risk of prostate cancer, including African heritage, family history with your brother or father, increasing age 50 and above. Men need to ask their doctor about screening with PSA blood test and digital rectal exam. You need to start talking to your doctor about PSA screening at the age of 40 if you are at high risk, and at the age of 45 if you do not have high risk. Before testing, no sex or exercise is recommended for 1 week. If you are in poor health or age 75 and older, the value of screening is limited. After testing, talk to your doctor to understand your results. Is your testing normal, or do you need referral to a prostate cancer expert? I'd like to draw a parallel between taking care of our health and driving a car, and leave you with a few questions. Do you want to continue driving dangerously, to stop driving altogether, or to navigate your car wisely? Thank you for your attention.
Dr. Stern, I want to thank you. As always, the information you provided was truly detailed and quite honestly, just the information that was the whole purpose of this evening. That's what we need to hear. And as a man, I appreciate all that information. Now it's my honor and privilege to introduce a dear friend and a great individual here in the city of Brockton, a true dedicated public servant to the city and all of her endeavors. And Ms. Phyllis Ellis is the president, of course, of the Brockton area branch of the NAACP. Phyllis, good evening.
Thank you, Mayor, and good evening to you. Good evening, everyone. I am pleased to be in such company of such an outstanding panel. The Brockton Area Branch National Association for the Advancement of Colored People began our wonderful partnership with AdMeTech Foundation and Good Samaritan Medical Center in 2015. Dr. Faye Stern and Lynn Cornelius have been dedicated partners. We also like to give thanks to Steve Bernard and Leona Martin, who actually introduced us to Dr. Stern. So thank you guys for doing that. In 2015, when we started our partnership, Clement County in general and Brockton in particular were in the leading position in the state for prostate cancer mortality and related disparities. The disparity factor alone was about 3 times higher mortality rate for Black men compared to white men for prostate cancer. Now, our branch and our partners, we host 2 or 3 events per year trying to bring awareness to prostate cancer in the Brockton community. And I think we have made progress. You will hear from Darren, who can actually attest to that. He's going to speak later on tonight. So I think hosting these events 2 or 3 times a year is beneficial to the Black men, because I think now more are going to get tested, and that is a good thing. We also are grateful to our strong advocates like State Representatives Claire Cronin and Jerry Cassidy and State Senator Mike Brady for fighting for continued funding for prostate cancer. And we look forward to our continued partnership with all of you. But let me give thanks to our outstanding health committee, Brockton NAACP Health Committee. Janet Trask is the chair. We have Steve Bernard and Leona Martin. But also at AdMeTech, we could not do this without Thomas Sathan-Fassett, because he's like the manager of everything. So thank you, Thomas. And we will continue our efforts to bring awareness about prostate cancer, because prostate cancer is a killer and it discriminates. Back to you, Mayor.
Phyllis, again, I want to thank you and your leadership of the Brockton area branch of the NAACP and everybody at the NAACP here in the city that are working collaboratively and dedicated their efforts to save lives. It's making a difference. And again, thank you, Phyllis, for your leadership. It's my honor and privilege now to introduce 2 well-known elected officials here. Senator Michael Brady, of course, is the senator for the 2nd Plymouth and Bristol District, and State Representative Claire Cronin, who is the representative serving Brockton and Easton, which is the 11th Plymouth District. Senator and Representative, good evening to you both.
Thanks, Mayor.
Thank you, Mr. Mayor.
Senator, I know that you're multitasking tonight. You have a couple of different district matters that you need to adhere to. So, although I was brought up always ladies before gentlemen, I'm not disrespecting the representative. I'm going to go to you, Senator, because I know you have another event as well.
Thank you. Yeah, I'm on 2 different Zoom meetings, and I've got to go to one for another community I represent. But I want to thank everybody involved with AdMeTech and on the committee at the NAACP. We work very well together in the city of Brockton, and this is an important endeavor, working with our colleagues in the State House to get the funding for the AdMeTech initiative every year. It's so important to bring attention to prostate cancer awareness, and we've seen the devastating results that it has had to our community. But preventive medicine is a key, and getting tested properly is a key. Same with the COVID-19 epidemic we're facing now. So I'm glad to Dr. Stern for bringing that to our attention as well and going over the numbers with that, and Dr. Herman as well. Fortunately, Brockton has started to move in the right direction where we're seeing the numbers increase in other parts of the Commonwealth, but we still, as we all know, we can't take this lightly. And social gatherings has been a big concern, especially, you know, in today's world. There's a lot of families living in multi-family homes and more than one family, and it spreads very rapidly when gatherings are like that. And I know that some of the parks where the social gatherings have taken place, it's a tough situation with the COVID. You want people to have free recreation and get out and have open and clean air, but we've seen what's happened when some of these social gatherings with the young people in the parks. And I'm glad that the mayor and powers that be have been staying on top of it. I know Ash Street Park in particular and James Edgar's Park, the people that monitor those have been doing a great job. But the important thing is educating our public on both initiatives. Not only the COVID-19, because we've got to keep the message going, how important and crucial this is, educating our public, but also with the awareness on prostate cancer. And I think that's the key, to keep spreading the word, getting the message out to our community and our citizens, and anything we can do at the state level to help. I know we're waiting for the federal government to see what they're going to come out with, a federal package. I don't know, the House of Representatives in Washington passed a $3 trillion package for financial help. I know the U.S. Senate, our local U.S. senators have been doing the yeoman's work, but the rest of the country, some of these senators have not moved the needle closer to the middle, and hopefully they can come up with a resolution soon, because we desperately need that money. And on another quick note, and I don't mean to beleaguer, but unemployment issues, and I'm sure Rep. Cronin can say the same thing. Number one cause we've been getting, people suffering with unemployment issues. And if the federal funding gets cut, we do have money in the state to continue that, but that's another issue. So on another note, if any of the people listening tonight, my office has been doing a yeoman's work, Alan, Donna, and Mike, 90% of the calls we've gotten, because there's a lot of people suffering financially. The small businesses have been suffering. People have been laid off from work. And again, that all goes hand in hand with this epidemic, taking care of your financial stability, your personal health, all of the above. So please don't hesitate to contact us as we move through this, both pandemics. So thank you for letting me speak first, Mr. Mayor, and I am going on another Zoom call, but I'll be back and forth. I've actually learned to multitask, and I've got 2 computers running tonight. So thank you for my assistant helping me out here, but I'll be back on once I go on this other meeting. So thank you again to everybody who's on the Zoom call tonight.
Thank you very much, Senator Brady. We truly appreciate it. And now I'm going to turn it over to my state representative, because I live in the district. State Representative Claire Cronin. Good evening, Representative.
Thanks, Mayor, and thanks, Senator. You did a great job. I've been asked to speak on the legislative perspective on building and creating a Brockton model for leadership on education and awareness in prostate cancer. So I think when I look at the model that has been built in Brockton, and it did begin with Dr. Stern and the NAACP, and going back to 2015 when I first got involved, I met Dr. Stern, Phyllis, Leona, Steve Bernard. You know, they spoke of Dr. Stern, about her passion, made me aware of the project they were working on. And it was one that we all as a Brockton delegation eagerly embraced. And we did so with the help of some of our fine doctors at Good Samaritan Medical Center. I can think back to, I believe our very first event was up at the at the VFW on a Friday night.
Yes.
And the place was hopping. And that's when we first sort of got it all going and tried to get the community to understand the importance of it. Yep. And if we're looking to build a statewide model, I think what we have done in Brockton really is a model that other communities can adopt. So at the legislature, what we have done, first and foremost, when we speak of our concerns, first we need passion on the ground. We have passion in Brockton. We have a great grassroots support. We have a legislative delegation, a mayor, city councils that are all eager and happy to get behind this effort. And we know that the work we've done in creating awareness has actually encouraged more people to be screened. You'll hear stories tonight, one especially from, I don't want to steal his thunder, but my good friend Darren Duarte can tell you a story about being at one of our meetings, and it spurred him on to be screened. And I think that's a really good starting point. What's also important is when there is an issue of concern in the community, and it's important to the community, we must fund it. And that is what we've done very well in the legislature. And here I'll have to give a great shout out to my House colleague, Representative Jerry Cassidy. Every year, Jerry Cassidy carries the budget for prostate cancer awareness in the House of Representatives. And when he does so as a lead advocate with our support from the Brockton delegation, but you can't do it alone. And we look to other delegations to support us in that. So they always say a budget is a moral document. You fund what you value. And I can say every year the funding for prostate cancer has, consistently gone up, or at the very least stayed the same. And this year we're going into uncharted territories with the budget. I have heard today that we might be working on a budget with a $5 billion deficit. But I can say as we go forward, this will continue to remain one of our very serious priorities. And in doing so, we want to spread the wealth and the success we've had in Brockton to other communities in the Commonwealth. So with that, I intend to present to the Gateway Cities Caucus, because we know this affects many minority communities, and many of our gateway cities have strong minority populations. So we're looking to spread this across all other communities within the Commonwealth. And I know that as our example, we always say we're the city of champions, but I believe we are the ones that championed this first as a city, and that was with the support of the wonderful members of our community. Dr. Stern, she just has passion and commitment relative to this issue. And with that passion and commitment, she really spurs us all on. And she is a well-beloved person at the State House. You can't walk through the State House without any rep or senator in the building knowing who Dr. Stern is. And we're all very happy to support her and support the cause. So with that, I'll send it back to the mayor, and let's hear from some of our medical professionals. Thanks for letting me join you tonight.
Thank you so much, Representative. Thank you for your dedication to the city and to the town of Easton, and for your leadership on Beacon Hill. Thank you so much. I'm going to go now on to Dr. Guy Fish, who is, of course, a distinguished physician, and he is the CEO of Selenex Company, which develops new frontiers in prostate cancer diagnosis. Dr. Fish, good evening.
Good evening, Mayor. Thank you for introducing me, and thank you to the AdMeTech team for hosting this event with the city and town of Brockton. Hello to all the elected officials. Thank you for your support in this very important matter. My background as an internal medicine physician has led me over the years to look at innovative ways to improve medical care for all people, and with a particular interest, of course, to my community, the African American community. I have three messages with regard to prostate cancer and the Black community tonight. One is that prostate cancer affects all of us in the African American community, and I'll elaborate on that more. The second is that if not addressed, the impact can be devastating. And overall, as African Americans, we have not been addressing it. Brockton is certainly engaged in the work and leading the charge, and I like your City of Champions motto, but there's more work to be done. And third, that there are new tools and methods to diagnose and manage prostate cancer and change our experience with prostate cancer. So those are the three themes that I want to go over with you tonight. So starting with prostate cancer affecting us all. People who are on this Zoom cast probably are here because they have friends or loved ones who have been affected by prostate cancer. And if you put your hands up, my hand is up too because my dad had prostate cancer. He was a chemist. His father was a schoolmaster. My mom was a nurse, an LPN, and her mother was a domestic. I grew up in Cleveland with three sisters, many of whom I was very competitive with. And when my eldest sister decided that she wanted to go to an elite girls' college, the only way I could better her was to go to Harvard. And I was blessed and was able to go. It wasn't easy. I was at Harvard, not of Harvard, as W.B. Du Bois says, but God is good. And after finishing there, I had the chance to do my medical degree at Yale. And I was there when I got the call that none of us want to have, a loved one, a family member, my dad, calling and telling me that he'd gone to the doctor and found out he has prostate cancer. I remember that day very clearly. I remember the feelings that I had. You go through fear and doubt and betrayal and sadness and compassion. And I want to tell you, the whole family goes through that. Maybe not all at the same time. Maybe you got a family member who's just coming to grips with fear and doubt, and you're already in compassion, and that's a challenge as well to manage as a family. My personal family story is good because my mom being in medicine, my being in medicine, we got busy. We plugged them into and took full advantage of the care that was out there and possible. My dad lived 15 more years before, and seeing the birth of 6 grandkids before he passed on and went home. So it does affect all of us, and I hope you can hear from that story that there's everyone in the family being affected by this, not just the men. For those who need an explanation about what prostate cancer is, because we assume a lot, and we should actually do the job of making sure everyone's grounded in this. The prostate is a small gland that's only in men. It's part of the sexual and reproductive system. It sits under the bladder and in front of the rectum, and its job is to provide fluids, lubrication, and nutrients for sperm as they usher forth. So prostate cancer is when it occurs when any cell and organ in the body, the controls of that on regenerative property of the cells are somehow undone. This means that instead of cells having a natural, normal lifespan, they start acting as if they're immortal. And our body has natural defenses against this. 99.999% of the time, our bodies are able to shut down that abnormal growth. But when we get a cancer that is detected by doctors, it's because that tumor has lost its controls and our body has lost control over that tumor, growing into serious health problems. So prostate cancer occurs when some cells in the prostate gland lose their controls and start acting immortal. Any man who lives long enough is almost guaranteed to have prostate cancer. It could be either very mild disease that will go on for years or decades without really having an impact on their health, or it could be very aggressive and actually take them out very quickly. So we all have fathers, and some of us have our fathers, and some of us have brothers, and so it affects us all. When I mention that if not addressed, its impact can be devastating. I think Dr. Stern did a great job of explaining that the impacts are inequitable between the general population of men and men of color in terms of the cause of death and the odds of death with this. The number one cause for Black men in America is heart disease. We're no different than anyone else. One exception being that if you shave that down to Black men between 0 to 45 years, number one cause is homicide. That's a totally different public health problem and meeting that we need to have amongst ourselves. But the number two cause is cancer. And among men, Black men in particular, prostate cancer is number one, followed by lung and colon cancer. If you are a man and you have prostate cancer, the number of men who get this is about 165,000 cases a year. for those of you who need some assistance imagining that, that's Gillette Stadium filled up 3 times over every year, getting the diagnosis of prostate cancer. As far as deaths go, one of those Gillette Stadiums filled, half of those men will die from prostate cancer in a year. So this is a big problem. We really do have to address this. And the issue is really about detection, as Dr. Stern said. As she mentioned, if you are detected early, you have almost 100% chance of survival after 5 years. And if you're detected late, only 28% are alive after 5 years. So clearly we need to be doing something. And if Black men are dying from this more frequently at 2.5 times the rate, we're not doing enough. So we want to screen early, we want to diagnose early, we want to treat aggressively. As Dr. Stern said, when to do it, if you're general male in the public, at age 50 you get screened. But if you're Black, you start at age 40. And if you have a family history, you start at age 40. You really do need to go see your doctor and discuss a PSA test. And the reason you need to discuss this and have self-advocacy is because the medical community of doctors has been back and forth on this issue for the last 10 or 15 years. There was a point about 15 years ago when doctors, urologists, who specialize in the prostate gland, were beginning to think we don't need to do PSA testing, or we don't need to do digital rectal examinations. And for a number of years, that was the case. They didn't do it. They backed away from it. And then they found out that the cases of severe prostate cancer coming late to diagnosis was going up. And those men were out of luck because it wasn't caught early. So the medical community is back and forth on this issue, but you as a Black man need to stand and advocate for yourself, that you want a PSA test, and if it comes back positive, you want a biopsy. Listen, nobody's in favor of having needles poked in unpleasant places, but if it's a difference between you being here for your granddaughter or great-granddaughter's graduations or the like, I think we need to get busy. So self-advocacy is a really important part of it. Dr. Stern mentioned some other statistics about how infrequently it may be for the cancer to actually be bad. We don't have a perfect way of predicting that either. And the company that I am leading, called Selenex, is leading the charge in creating improved ways for men who have a biopsy, determining whether or not that prostate cancer is actually aggressive and needs aggressive care or not. I won't go into many of the details about that, but we are looking forward to launching a number of new tests to help in the conversation between men and their doctors about what to do with their prostate cancer, and particularly for African American men, because having multiple conversations with your doctor is the thing that needs to be done that often isn't done with Black men. So in wrapping up, prostate cancer, particularly in the African American community, affects all of us. If not addressed, it can be devastating, but we as a community are looking and doing more. Brockton is leading the charge, so thank you for that. There are new tools and methods, but it takes a lot of self-advocacy to get in front of the physician and actually insist that you have a PSA test, and if that's positive, a biopsy. So thank you for that. I'm going to turn it back over to Mayor Sullivan to introduce the other clinical panelists.
Thank you. Thank you so much, Dr. Fish. I truly appreciate all the information. And I want to just take a quick moment because, like Dr. Fish, my dad also, I can remember the day my dad told me he had prostate cancer. And the first thing I did was I ran to Barnes & Noble and bought every single book I could find on prostate cancer. And when I called my dad the next day, I said, "Dad, who is going to be your clinician at Good Samaritan Medical Center?" And he said, "Jason Zalls." And I knew Dr. Zalls because I served 10 years on the board of directors at Good Sam, and he's a hell of a doctor, but he's a hell of a nice person. And I knew my dad would be in really good hands with Dr. Zalls, and my dad just turned 80. So it's a success story, and it's my honor and privilege to introduce Dr. Jason Zalls, Clinical Director of Oncology Services at Good Samaritan Medical Center here in the city of Brockton. Dr. Zalls, good evening.
Good evening. I'd like to thank Mayor Sullivan for the introduction. That's very kind of you. Also like to thank Dr. Faina Stern and the AdMeTech Foundation for allowing me to participate again. It's really nice of you to do so. And more importantly, I'd like to thank the champions of the City of Champions and the NAACP, as well as our elected officials for putting this on year after year. It's been great. It's been fantastic. The Brockton community deserves all of you, and thank you very much. I was asked to talk about the current clinical perspectives and the current state of art in prostate cancer treatment and diagnosis in 10 minutes. That is a lot of territory to cover, so I'll try my best. I'm going to try to share the PowerPoint here. I got to remember how to do this. All right, so basically updates in prostate cancer care. There's some really nice clinical trial that radiation oncologists as well as surgeons know about prostate cancer. That was kind of one of the groundbreaking oncology trials for prostate cancer, as well as some innovations that we see in our community hospitals and stuff that we have in our local Brockton area, as well as a new diagnostic testing for prostate cancer recurrence. I think is important and we utilize it regularly. So this is a study published in the New England Journal of Medicine looking at prostate cancer treatment. This is always the question is whether or not we should treat prostate cancer, and more importantly, how best to treat prostate cancer, whether that be with surgery or radiation therapy. But we also have something called active surveillance, and this is something we've moved to over the years and not over treating prostate cancer. Not all prostate cancers need to be treated. We have certain criteria that we use to group certain men with prostate cancer into certain groups. And based on which group they fall into, we then have better treatment options for them, depending on how aggressive the prostate cancer is. So this was a study that was looking at men for with basically low and intermediate risk disease, not high risk disease. And they're basically randomized men to either three options, either active surveillance, having surgery with prostatectomy, or having radiation therapy. And after 10 years of follow-up and assigning these men, what they found is that at 10 years, the prostate cancer specific mortality was basically 1% over a 10-year period of time. So basically, you can see this graph up here. There's actually three lines. You can't see them because they're all overlapping. And the red color is for surgical arm, the blue color is for radiation, and the green is active surveillance. And basically what active surveillance is not treating the prostate cancer. It's rechecking the PSA every 6 months, possibly redoing a biopsy every 1 to 2 years. So these men actually, most men didn't get treatment. But over a 10-year period of time, all these lines are overlapping, meaning that all these men did not die of prostate cancer. And so basically when you get out to 10 years, that 99% of men who had active surveillance didn't die of prostate cancer. 99% of men who had surgery did not die of prostate cancer. 99% of men who had radiation therapy also did not die of prostate cancer. Now, being alive or dead is one thing. That's a kind of a binary thing that we like to say. It's either 0 or 1. However, there is also an intermediate group, and that intermediate group is when we have cancer that's spread beyond a treatable area. And these are the patients we're really looking out for with prostate cancer, because in general, the life expectancy with men with prostate cancer is pretty long, especially with low and intermediate risk disease. This graph down here in the bottom here is this. You'll see the blue and the red are basically patients who undergone either surgery or radiation therapy. And you can see the green line down here, which is the active surveillance arm. These are men who did not get treated. You start seeing this curves are separating. And what this basically shows that for clinical progression, about 23% of men after 10 years had clinical progression on this trial if they were undergone active surveillance, while only half of those men in either surgery or radiation therapy had clinical progression. So what we're seeing is that at 10 years, there are some men who are on the active surveillance arm who their cancer actually spread. It actually became incurable because more men after 10 years ended up having, basically who were on the active surveillance arm, ended up having cancer that had spread to the bones, no longer curable, causing their quality of life to suffer. Less men in the surgery or radiation arm had the cancer spread to the bones. The other important part of this, about half the men who were on the active surveillance trial or on the active surveillance arm of this trial, half the men ended up actually getting some form of treatment for their prostate cancer. So even though they're on quote unquote active surveillance in this arm, in this green arm here, half these men actually ended up getting treatment because their prostate cancer had regressed. So the good thing about this trial is you can see that radiation therapy and surgery are equally effective in terms of curing prostate cancer, but also preventing it from coming back, more so than active surveillance. But that's at 10 years. But most of the men we like to look at, this trial basically shows that patient selection and patient discussion is so important. And basically we want to make sure that most of these patients have life expectancies more than 10 years before we treat. Otherwise, it's better to shake their hands and say, have a good time, enjoy life without any treatment. But their life expectancy is more than 10 years. These are men that certainly can start dying of prostate cancer when they're on active surveillance. And it's important to have the discussions with them regarding their treatment options, as well as the potential side effects of treatment. And in fact, a follow-up to this study, I think published in the last year, did show that more men started dying of prostate cancer than who were in the treatment arms. So again, study conclusions, basically appropriate patient selection is important in prostate cancer. Patients with early stage disease can be watched with active surveillance. It doesn't mean we get rid of you, we don't talk to you. It's basically, we want you to see you every 6 months. We recheck the PSA, possibly also do a biopsy again. Surgery or radiation therapy are also very good options for patients who wish to have some form of treatment. But it's important to have a discussion with the patient, with your provider, regarding which risk group you fall into, whether you're low risk, intermediate, or high risk group. It's important for us to evaluate your overall health, what we think your life expectancy is, your age, and also not just your physical age, but also your how healthy you are, your overall performance status, as we like to say, and then choosing options that are best for you, and going through those options very carefully. One of the things that we do at Good Samaritan, as well as we've been doing it in Brockton for a while now, but also throughout the country. One of the great new things is one of the issues with radiation treatments for prostate cancer. It generally has a really well-tolerated side effect profile. Certainly early in the treatment, we can get some urinary bother. But one of the issues is we can sometimes get late rectal toxicity, which it doesn't occur very often. When it does, obviously any kind of rectal irritation from treatment is not very good for the quality of life. So we're always trying to figure out ways to improve and lessen the amount of side effects that patients have from their prostate cancer treatments. And one of the things, and the reason why we have some issues with this is kind of taking a human body and cutting it right down the middle in half. This yellow, I kind of color coordinated things here. Yellow is for the bladder, holding the urine. The brown line here is basically the rectum, where the stool is. And the green here is the prostate, and kind of like this reddish area covered is basically how radiation is given. And you can see right here that this little brown line here is part of the rectum, and that rectum actually falls into the high dose of radiation field. So this is one of the reasons why we actually get patients with increased rectal irritation after radiation therapy that can sometimes happen. There's nothing we can do to avoid it. The radiation has to go there. It's just one of the unfortunate side effects we get. Generally not too bad, but something we would rather not have. So you can kind of see here on this left-hand side, and this, I don't want to be marketing for anything, but this is a product called SpaceOAR, and this is an MRI. This MRI, this little circle here is the rectum, and this area up in front of is the prostate. So you can see again how the rectum closely abuts, if not touches, and kind of drapes over the prostate almost like a blanket. So what they invented is they invented a little gel. It's basically a water-based gel that they actually place. This white area here is called the spacer. And the SpaceOAR is a little gel that gets placed, and you can see now it separates and it gives a distance between the rectum back here and the prostate up here. About 6 months after the gel is injected into the body just reabsorbs it and it goes away. So it's something that's been, they did a randomized trial putting men on using this SpaceOAR or this hydrogel SpaceOAR, and they compared it to men with and without the SpaceOAR, and they found that it clinically reduces the risk and statistically significantly reduces the risk of late-term side effects from radiation therapy to the rectum. It's been FDA approved, as well as Medicare coverage for it, for this kind of treatment. And this is kind of what it looks like after someone injects it. So again, the yellow color coordinated here. The yellow is the bladder. This right here is the prostate. Back here is the rectum. And now you can see the SpaceOAR creates a space. So the rectum is no longer kind of lying on top of the prostate. So that gel gets placed there. And again, the body reabsorbs it. So this is, again, you can see the problem here where the rectum was kind of falling into the radiation field. Nothing I could do about it. Now when we place the SpaceOAR, this green area here is the SpaceOAR, and you can see it creates a buffer zone. It creates a buffer zone where I can deliver my radiation therapy. I can deliver even now higher doses of radiation therapy, which allows me to decrease the number of treatments patients have for radiation therapy for prostate cancer. So this is what we often do with our patients. It's one of the things we do in the community, I'm sure, as well as the academic centers. I'm sure Dr. Mahal has used this before. It can be used on various ways we do radiation therapy. Getting down to short courses, as few as 5 to 6 treatments of radiation therapy, allows us to reduce our radiation therapy treatments from usually an 8.5-week course as a traditional type of radiation therapy. Now, most radiation therapy treatments for prostate cancer are moving down to like 5.5 weeks, if not less. One of the last things, and kind of just go over this quickly, again, I'm not trying to market anything in particular here, but one of the issues with prostate cancer is it does come back sometime. It can come back after surgery. People wonder how. All I say is, one little cancer cell that's left behind comes back. Cancer can come back after radiation therapy too. And this is a kind of a case study, and I have many of these kind of patients on the basis of a patient who had a healthy guy, 70 years old, probably healthier than I am now, which is pretty sad for me to say that about myself. He's a really healthy guy. He ended up getting a prostatectomy in 2013. He had a pretty high risk disease, and he had a biochemical recurrence, meaning his PSA came back, meaning his cancer's back in 2015. We couldn't find it. We did CAT scans at the time. We did bone scans. We didn't find it. We have no idea where it is. In general, when we get these patients, we can't see cancer anywhere. There's about a 70% chance that if we treat the prostate bed, meaning where the prostate was, with radiation therapy, the PSA usually responds and goes down, meaning that the cancer was left behind in the prostate bed. So we gave him radiation therapy to his prostate bed in 2015. Unfortunately, to my friend here, his PSA continued to climb up. That means it wasn't there. That means the cancer somewhere. We had no idea where it was. The bone scan was negative. The CAT scan was negative. We couldn't find it. Well, it's a newer PET scan that's specific for prostate cancer. It's called 18-fluciclovine, and it's basically a molecule that tags to the basically binds to the prostate cancer cells. So he said, well, why don't we try this? And usually this patient, he would watch his PSA, he would watch it march up, and then eventually he'd be put on androgen deprivation therapy, which basically blocks your testosterone. And there's a lot of side effects to having men on long-term androgen deprivation therapy. There's muscle loss, there's abdominal weight gain, there's hot flashes, there's decreased libido, there's bone mineral density loss. It's a drug that works well, but unfortunately, when you use it long-term, and if you have a biochemical recurrence of prostate cancer and we use it, it does cause side effects. So we said, okay, let's see if we can use this. Another kind of, at that time, was a newly FDA approved scan. Here's his scan up here on the left-hand side. This is his whole body. Just liver uptake is normal. What you can see here, he had a little lymph node. This is where it lit up. You can kind of see it here in the picture. It's a little area. This is where this particular study found where his prostate cancer is. Now, it doesn't mean it can't be elsewhere in the body, really microscopically, but overall, he had this little lymph node here, and it showed up. Now, this gentleman, interestingly, had his lymph nodes removed at the time of surgery back in 2013. I went back to his CAT scan back in 2013 and looked at it, and you can actually see this little lymph node sitting there that slowly grew over time, and that was beyond what we would normally call size criteria for a pathological involved lymph node. So this little itty bitty thing grew over a 5-year period of time. So talked to him about his options. Guy's a healthy guy. One of my favorite patients. He said, "You want to be aggressive with this? Do you want to treat it?" He said, yes. So what we did radiation therapy. I treated that particular lymph node as well as some other lymph nodes in the area, given that there could be a risk. His PSA, when we saw him originally, was 2.38, which is pretty high for biochemical recurrence. We treated him with radiation therapy to that lymph node, and we dropped it basically down to undetectable levels. And he's been disease-free at 2 years. And more importantly, for this gentleman who's very active, he hunts, he goes out exercising all the time. He's, again, more active than I can ever be. He doesn't need his androgen deprivation therapy. He's been able to stay off that kind of treatment, which is very helpful for him. So I believe that is my last slide, so I don't want to take up too much time. But overall, just kind of going through things, we have lots of options there in the community. There's lots of options for radiation therapy. There's lots of options for surgery. There's high intensity frequency ultrasound treatments that we also have in the community that people are using for prostate cancer. And just to kind of or give a little horn toot to my community, if anyone's listening out there, the Brockton community, the Brockton hospitals did an incredible job through an incredibly difficult time with the COVID pandemic. It was absolutely crazy. We had to make tremendous amounts of modifications for inpatients, but even as an outpatient, a cancer facility, trying to figure out who's going to get treated and who's not. And for prostate cancer, we were able to a lot of times divert these patients and hold their treatments for 3 to 4 months to make sure we get these older gentlemen, kind of safely at home. Now we're starting to bring them back for their treatment. There's some cancers we couldn't hold, and we did treat a lot of COVID positive patients and had special precautions, to do that. And the medical community in Brockton really pulled it together and did a fantastic job. I'll turn over the mic now to Mayor Sullivan.
Dr. Dulles, thank you. Thank you very much. Very, very informative, and the visuals were very, very, very helpful to a non-medically trained person. So thank you for that. And I just want to echo the sentiments. And as Mayor Brockton, I just want to thank all the hospitals and Neighborhood Health Center and the VA hospital One thing that Rick Herman and I do is we have, it was 3 times a week, Monday, Wednesday, and Friday. Now it's Monday and Fridays with all the hospitals and Neighborhood Health Center and Father Bill's Mainspring. This is all about COVID. And on the first meeting, I just said, competition aside, ego aside, this is about working together in collaboration. And to every single person, this is weeks and weeks and months later, we're still doing that. So kudos to all the frontline staff, from the doctors to the PAs to the nurses to the cafeteria workers, security guards, everybody that was putting their lives on the line to save lives. So thank you, Dr. Zalls. Now it's my honor and privilege to introduce Dr. Brandon Mahal, who is assistant professor in radiation oncology, University of Miami Miller School of Medicine, and also an assistant director of community outreach and engagement at the Sylvester Comprehensive Cancer Center. Dr. Mahal, good evening.
Good evening. Thank you, Mayor. Thank you to Dr. Stern for inviting me to give this talk, and thank you to the community of Brockton. And also, it's a real honor and privilege to be able to present after Dr. Fish and Zalls, and also after Phyllis. So it's a real pleasure. And I hope to give you some information today that is both helpful in terms of describing prostate cancer, some of the controversies, some of the advances in diagnosis and treatment, and also the impact of prostate cancer disparities on those topics, especially in the era of COVID-19. Mayor, like you were saying, Brockton was one of the hot spots. If you overlay hotspots for COVID-19 in America, you'll see the same hotspots are where there are hotspots for prostate cancer and diseases like prostate cancer. And the reason is because of disparities. And we're seeing these diseases greatly impact the Black and minority communities more so than other communities. So in medicine and in policy and everything we do, as we engage in activities to ensure the health of our communities, we need to be thinking about this. So I'm going to start a presentation here, and I'm going to do a screen share. All right, so prostate cancer disparities and implications for emerging advances in diagnosis and treatment. So this is a slide here just to summarize some of the things that have already been discussed, but to put some numbers to them. So Black men have a higher lifetime probability of developing and dying from prostate cancer when compared to white or other men in the US. And so when you look at those numbers, what is a Black man's lifetime risk of developing prostate cancer? That risk is 1 in 6. And the risk of dying from prostate cancer for Black men is 1 in 23. And when you compare those rates to white men, it's 1 in 8 versus 1 in 42. And so to put that number into context, like Dr. Fish was giving you, that there's about 170,000 men diagnosed with prostate cancer every year, and about 28,000 men that die from prostate cancer every year. If you look at the number of deaths that are just due to disparities alone, just disparate deaths, there's about 4,800 total prostate cancer deaths that are in Black men, which translates over to about 2,500 excess prostate cancer deaths, meaning if there were an equal number of deaths in Black and white men in terms of the rate of deaths, then we should be able to reduce the number of deaths in Black men by 2,500. So there's 2,500 deaths due to prostate cancer disparities in Black men annually. That's every single year. So I'm going to go on to the next slide here. If you look at what the rate looks like in terms of the rate of prostate cancer across decades, here's in the 90s, here's in the more recent times, 2016. And if you look at Black men that are highlighted here in green versus all other men, including Asian Pacific Islanders here in the blue, American Indian, Native American, or white men, you see that the rates of prostate cancer have consistently been higher for Black men. And as the rates of death have come down over time, you ask why, but still there's a big gap in terms of the difference between the number of Black men dying compared to the number of other men. And a big reason why this started coming down a little bit more so you see for Black men than other men is most likely because of PSA screening. So I'm going to skip this slide from now and come back to it. But PSA screening, it's a routine blood test. It measures your PSA concentration in the blood for men, and any levels that are above 4 are considered abnormal. And so the key thing about prostate specific antigen screening is that for men who are detected with early prostate cancer, they have a greater than 98% chance of surviving beyond 5 years. But for men who are detected later on, not from PSA screening, so because they have symptoms, because they have bone pain because the disease spreads to their bones, or it's enlarged so much that they're having urinary issues or rectal issues, those men, only 26% of them survive beyond 5 years. So screening is a huge tool for prostate cancer, and it's one of the best screening tools we have out there across all different cancers, and it saves many men's lives. But still, there's a lot of controversy about the PSA test, and in 2012, the United States Preventive Service Task Force made a grade D recommendation against routine PSA screening. And the reason was because the studies showed that you needed to screen over 1,400 men in order to save one man's life. And in the process of doing that, there was concern that some men were being treated for very indolent forms of prostate cancer when they didn't need to get it. But the key thing is that this study result was only at 9 years of follow-up. And prostate cancer, when compared to other kinds of cancers, it's a more slow-growing cancer. It takes a longer time from the time of detection to the time that cancer can become dead or deadly. And so really, you need more than 10 years. You usually need 12, 15, 20 years of follow-up to see what something like this would do for prostate cancer. And so all the experts were banging their heads and hands and saying, hold on, wait, you're evaluating this too early. You're making this recommendation too early. And so when looking at what that was at 12 years of follow-up, so just 3 years more, it cut the number down to only 781 men needing a PSA screening test in order to save one man's life. So we already almost cut that number in half. And so what did the task force do? They went back and they said, okay, for men age 55 to 69, you can make a decision with your doctor about whether or not you want the screening, but we're not going to recommend that you get it routinely. So it's totally up to you. And what that has created is a lot of confusion for clinicians and patients, because there was the 2012 recommendation against screening, and now there's a sort of 2018 update saying it's up to you if you want screening. So really, patients need to be their own advocate in asking for this, because there's a lot of stigma about the PSA test now in a lot of the primary care communities, and there's just a lot of confusion even among doctors. So it's really important to do this. And the thing that Dr. Stern and Dr. Fish were bringing up as well is, hey, what about men who are at risk that have a family history or that are Black? And the thing that we know about studies in medicine is that screening exams, they're more efficacious in populations where the disease burden is higher, where it occurs more frequently, and where the disease is more deadly, which is in Black men. The issue is that in the screening trials that those recommendations were made on, there were only 4% Black men in those screening trials. And so what the task force services said is that because of the available evidence, they're not allowed to make separate recommendations based on race. But what I can say is that if you identify as Black, and if you have a family history of prostate cancer, I guarantee you that if we had a large enough study and we were able to do this, it would show that you are more likely to benefit from screening than others. The number needed to screen to save one Black man's life is less than others. And so it's much more important for Black men or patients or people with a family history to get this PSA screening. So what about other things? The other thing I want to talk about is treatment. All right. So the other thing that can lead to disparities is just differences in treatment. And we know this because in studies of radiation treatment trials, when combining all of the patients who were in those trials, looking at over 5,000 men with over 1,100 Black men. Now, this is a major exception in a lot of the cancer literature. And studies, Black men are very underrepresented in prostate cancer studies, and Black patients in studies from all different diseases are very underrepresented. For Black men and prostate cancer, it's not uncommon to see less than 1% of patients on those trials. But the radiation cooperative group back in the 90s really made an effort to bring on a lot of Black patients, and they had over 20% Black patients in their trials, which allowed a combination of 4 different trials onto a study where you could look at, hey, what about when patients are on a study, all getting the same treatment, all getting the same care? How do they fare? And what was seen in this study is that actually, when patients get equal treatment, they tend to have equal outcomes. And so that's a huge and important fact to know, that when folks get equal treatment and access to those equal treatment, that's a major thing that we can do right now to reduce disparities. There's a lot of barriers to getting equal treatment, and those are things that we have to do on the medicine side, on the policy side, and in the community to make sure that men are getting equal treatment so we could reduce those disparities. But that being said, if you look at I'm going to just show you some math here, and to say that's only a part of the study, a part of the story. So there's about 101 white men diagnosed for every 180 Black men with prostate cancer, and that translates over to about 18 white men versus about 40 Black men who die from prostate cancer every year. So this is about 2.2 times higher mortality rate for prostate cancer in Black men every year. If you assume that all of these men getting prostate cancer had the same rate of death, about 18%, there would still be a huge difference in disparities. And that would be about a 1.8-fold higher mortality. So even if we give equal treatment, we need to figure out why Black men are getting this disease more often. And that's going to be a major way to address prostate cancer disparities as well, because that drives a lot of the mortality differences. And so the last thing that I'm going to finish with is the use of precision medicine and genomics, and what are those implications and prostate cancer disparities. So what we're doing now in medicine a lot of the time for a lot of different diseases, but especially for cancer, is we're using genomics, tumor genomics, and also the germline genomics of what you inherited from your family, to both come up with models to predict how aggressive your disease is and to develop our therapies. And the unfortunate thing is that those studies are highly Eurocentric. So those studies have really included lots of patients from European ancestry, but very, very few patients from African ancestry or other ancestries. And what we're seeing is that those prognostic models, when you look at them in either ancestry-linked studies or studies where patients give their self-identified race, those models may not work as well in other populations. And on top of that, we're creating these drugs and these targeted therapeutics that may not work as well in other populations. And so we're presenting ourselves with this ethical challenge where we may worsen disparities without representative studies in precision medicine. We may artificially create biological disparities through our social use of these studies. And so when looking at tumor genomics, when looking at different tumors and taking the biopsies or the pathology from surgery and looking at the genomics in those tumors and markers that predict for aggressive disease, what we've seen is that what this image is meant to show is that there's differences in these markers of aggressive disease by race. And on this side, these are certain markers that would be found higher in Black patients or Black patients with African ancestry. So their ancestry genomics was actually analyzed in these studies as well versus European ancestries. And these are markers that had that were lower in patients with African ancestry. So when looking at some of these studies, and even though there's only limited number of Black patients in these studies, we're seeing differences in markers, important markers of disease. And that, again, it just shows that the importance of having diversity in these precision medicine studies. And the last thing I'll present is a study that I just had that came out, I guess, this week in the New England Journal of Medicine. Was a study of over 2,300 patients, including 204 Black men. The sad thing is this is one of the largest studies of prostate cancer genomic profiling. in Black patients, and there's only 200 Black patients in the study, and we need to do better. I'm embarrassed when I see that. We examined 474 genes across race and stage of disease, and what we found is that Black men, so I'm just going to focus on this side. These are markers of aggressive disease or markers for drug targets in patients with metastatic prostate cancer. This label here, AR, is for androgen receptor, and androgen receptor is one of the main targets for prostate cancer treatment. That's what hormone therapy targets, for example. The rate of mutations in Black patients, which are depicted here in the blue line, versus white patients in the red line, or Asian patients, is significantly higher. Black patients had a twofold higher frequency of mutations in that receptor gene. And what that means is that Black men may be more resistant to those kinds of therapies. But the other interesting thing is that Black men were more likely to have alterations in quote unquote actionable genes in the metastatic setting. And these are genes that have drugs that are directly targeted to those genes. And so the reason that that's important is because we're doing these studies of these precision medicine therapies. You hear about immunotherapy, you hear about these new targeted therapies. All of those things are targetable precision medicine drugs, and those studies do not include a lot of Black patients. And what we risk is not accounting for the diversity that's out there also in genomics. You know, race is a social construct, but being Black is a real thing. It's not a zodiac sign. And so that there's ancestry that tracks with that. There's differences between races for different reasons. A lot of it can be driven by culture, by diet, by exercise. The experience of structural racism can change your genetic code and can make diseases present more aggressively. And so this is a completely new era of medicine. And we need to be sure that we have representation so that we don't create worse issues and so that we better understand mechanisms of disease. Thank you.
Thank you very much, Dr. Mahal, and your information is truly informative, and it really speaks volumes. So I truly appreciate your time tonight. I really do. Thank you.
My pleasure.
The last individual is a great Brocktonian, and again, a wonderful public servant. Worked at City Hall, now works over at the Police Department as Director of Communications and Outreach. And Darren Duarte, who again is also a survivor of prostate cancer. Darren, thank you so much for joining us this evening.
Thanks for having me, Mayor, and I want to thank all the folks on this panel of delivering this message and the information, and Dr. Stern, Phyllis, for having the event that you've had since 2015. I started going to those at the beginning, but like many people who I think were in the audience, I went and I wasn't thinking that could happen to me. Meaning I didn't go get tested. I didn't go see the doctor and talk about prostate cancer. I went a second time, same thing. After talking to Dr. Stern, though, in one of the sessions, I think it was at on the South Side, we had a conversation, and she talked about how we need to be our own advocates, especially men of color. So I said, and I promised, I'm going to get tested. So I did. I got tested, and I didn't really hear much back from my physician, except to say, look, it's kind of high, go see a specialist. I went to go see the specialist, and the specialist, again, didn't respond as if there was a problem. And I asked, oh, is there a problem? Or do I have cancer? Oh, we'll just keep checking in and just watching it. A few months passed. I went again and took a test, and still the answer was no. We think you're fine, so come back again in another 6 months. And then I started thinking about what Dr. Stern and others said about being your own advocate, and I started researching. and figuring out what these numbers mean. And then in talking to some people, the number that I had was a pretty high number. So I called the specialist back and said, I think we should have a biopsy, don't you? Ah, sure, why not? Had the biopsy, and when I got the results back, the results were shocking. So shocking that the urologist's face turned red. And he says, you've got prostate cancer. And you've got it bad. It's on the move. I hope it's not too late. We have to act fast. And luckily for me, we did act fast. Within 4 to 5 weeks, we checked, make sure it didn't get in my bones, make sure it didn't leave the gland, although it was on the cusp of leaving the gland. Had surgery, and thank God, and thanks to all my friends and all of you, we caught it in time and it did not spread. And I'm still cancer-free after, this was July of 2018, I had the surgery. So I can tell you that when you listen to these messages and listen to people, and sometimes you think, oh, this cannot happen to me, but it can. And even if you wait sometimes on the doctor, you know, they're seeing a lot of people, they should be able to catch these things, but you know what? I've heard this today from many of you, and it's true. You have to be armed with information, and you have to be your own advocate. The doctors told me that if I kept going like nothing, like there was nothing and nothing was going to happen, and I didn't have surgery, they wouldn't be surprised within a 5-year period that I could have been dead. Now, that doesn't happen to everyone, and I get that. Usually, this disease is a slow-moving disease, like many of you have said. But in some cases, that's not the case. In some cases, it's a fast-moving disease, and you know, who knows how long I had it before we detected it with the biopsy. So I'm just thankful that I live in this community. We're going to these events, and I had you know, the NAACP and AdMeTech talk about the importance of not only going to get checked, but knowing what you're getting checked for, and to ask questions. And that's basically what I wanted to talk about, and talk about how it's real life circumstances. And when you hear these things, numbers and symbols and percentages, you know, it could be you. So we need to take, you know, matters in our own hands. And I know a lot of Black men who don't like to go to the doctor and don't like to go specifically for this, to get checked for this, but it's important. And everywhere I go, and every chance I get, I talk about my experience and talk about I'm lucky to be here because of not only people who arm me with information, but people who told me how important this was for all men, especially men in my community. Mayor?
Darren, I just, on behalf of everybody here and everybody watching, thank you. Thank you for sharing that personal story. That itself is going to save a life, because someone's going to say, if it could happen to Darren Duarte, and being your own advocate, that's the takeaway, be your own advocate. And so, I mean, I know you don't shy away from it. Some people do when they have the word cancer, but you
right.
head on. And that conversation you just shared, those 4 minutes right there, is going to make a difference. So on behalf of everybody here, thank you, Darren. Thank you for taking the time to share that and everything that you're doing in our community. I really appreciate it as mayor, but as a friend. Thank you.
Thank you.
I want to just take a moment to thank everybody that participated tonight. State Representative Claire Cronin, State Senator Michael Brady, Phyllis Ellis, again, the president of the Brockton area branch of the NAACP, Mr. Darren Duarte, the doctors, Dr. Rick Herman, Dr. Stern, Dr. Fish, Dr. Zolls, Dr. Mahal, the Good Samaritan Medical Center, again, the Brockton NAACP branch, and AdMeTech Foundation. I found this extremely, extremely valuable. And I know that each and every one of you has a cause in life and a passion to save lives. That's why you went into the medical field. So I want to applaud each and every one of you. I want to thank you. My wife's a physician assistant, and you have a daunting task in light of COVID. And I want to just thank you all. And I want to thank Phyllis for asking me to host this tonight. And course, Claire and Mike for their diligence and representation, and Jerry Cassidy. Jerry's always on here. And as Representative Cronin said, he has always been an advocate. So thank you. I wish you all a good evening. Stay safe, be well. God bless. Thank you.
God bless.